Good afternoon. Thank you for joining us today. I am Cassidy Ovula with the Center for Optimizing Rural Health, also known as CORE, and I am very pleased to welcome you to this webinar on telehealth in a post-PHE world. Dr. Kathy Wiberly with Mid-Atlantic Telehealth Resource Center will be our presenter today, but before I introduce her, just a couple of housekeeping items. We are recording the webinar and we will share a link to this recording as well as a copy of the slides with you in a follow-up email. So if you'll give us about 24 hours to get that posted, you should receive an email from CORE and you'll be able to play back the recording today as well as download the slides. There will be time for Q&A at the end of our presentation, but feel free to drop your questions into the chat box during the presentation if you like, and I will make sure that Dr. Wiberly addresses them during the Q&A. So it is now my pleasure to introduce our speaker. Dr. Wiberly is director of the Mid-Atlantic Telehealth Resource Center. TRCs are federally funded to assist with telehealth program development and sustainability in order to increase access to quality care for rural and other underserved populations. Kathy is also Director of Research for the Karen S. Rubin Center for Telehealth, Assistant Professor of Public Health Sciences at the University of Virginia School of Medicine, and faculty member at the Healthy Appalachia Institute. Kathy's public service career reflects over 30 years of experience in public health, public policy, program development, program evaluation, and strategic planning. She is an appointed member and chair of the Rural Health Committee for the Universal Service Administration Company Board, and is vice president of the Virginia Telehealth Network Board. In her not so copious free time, she enjoys playing competitive volleyball, recreational softball, and trying her hand at wildlife photography. All very interesting. So welcome, Dr. Wiberly, and it's all yours.
Great, thank you.
Yeah.
All right, you can see my slides, I assume. All right, well, we are going to be talking a little bit about telehealth in a post-PHE world. And just to give a little context of how we got here, prior to COVID, telehealth was basically the turtle and the hare kind of scenario. So it was slow and steady. Telehealth has been around, and most of you know, 30 years, over 30 years. And it's grown each year, but it's never had an explosive growth until COVID came along. When that pandemic hit, we saw basically the digital transformation of just about every healthcare entity, system, hospital, you name it. There were, many that were involved in telehealth, but it was mostly specialty care. And suddenly we saw everybody enter this scene. And so, just in terms of the context, like, why did it actually take a pandemic to create this explosion? I think part of it is that slow diffusion of innovation. We talk about that 17-year gap between evidence and patient care, and how that translates. And I think that is a large part of it. As I said, telehealth has been researched. It's been around 30 plus years, but it's just been very slow. It rarely was introduced in many of the health professions education programs. And so people were really just learning about telehealth and how to use it, hit or miss. It also was not like this culture of innovation was rarely supported by the policy environment. And that was also one of the biggest challenges that telehealth faced is, and I don't know about Texas, but I know here in Virginia, we had this like whole chicken and the egg issue constantly. It was like, show us that it works before we pay for it or before we enable policies for it. And then we say, well, we can't show you that it works because you're not paying for it. So how, and it just keeps going on and on. And so what happened at the pandemic was that all of these barriers that people faced basically got eliminated in about 3 weeks' time. Licensing, credentialing issues, HIPAA, Ryan Hate Act, Stark laws, supervision requirements, scope of practice issues, co-pays, frequency limits, like reimbursement, all of those things got wiped out. And so many people entered telehealth during this time. And so most people who entered during this time had no idea what the environment was prior to the public health emergency. And so I think this is where we are at right now. So a couple of key things that people learned, everyone from policymakers to clinicians, was that telehealth technology is simply a tool, right? In the clinician toolbox, it's not a separate service. So we figured that out. It's not just for physicians, NPs, and mental health professionals. We also figured out that dentists, occupational therapists, I mean, you name it, they're using telehealth and using it effectively. We also learned, and mostly the providers learned, that it's not in-person care versus telehealth, but in-person care plus telehealth. So we're moving toward this hybrid model. And it's a model that policymakers oftentimes don't understand, and certainly reimbursement doesn't quite understand it, because we're learning that telehealth is more than just a substitute for in-person care. I think people were approaching telehealth as, well, if I do this in person, how do I do this same thing in a virtual setting? What we're learning is you may do some things in person that don't translate to a virtual setting, but there are some great things you can do in a virtual setting that you would never do in an in-person setting. For example, remote monitoring. You would never have a patient come to your office every day to get their blood pressure checked, but you can do that with remote monitoring. So now we have to figure out, how do we align our policies to this new reality? So after the public health emergency, we really can't go back to business as usual. And I think our policies are starting to figure that out, policymakers. We've interrupted and disrupted the status quo. We've had temporary policy changes that are moving toward permanency. We've seen significant investments being made to expand broadband. And we've had workforce shortage, clinician burnout, all of these issues that have been exacerbated by the pandemic. So what next? We now know that the public health emergency will end, or at least, unless something changes significantly, will end in May. We have had a number of things. So at the state level, most of the state waivers have already expired, which impacts mostly licensure, but those have expired. We've had this moving target for about a year now. So we had CMS releasing the physician fee schedule back in December, which made some of those things permanent in terms of reimbursement. It also continued this category 3 code, which means these are things that we want to continue to look at. So we're going to give more time to examine whether these should continue to be made permanent, but they're giving it a year, more than a year to do that. We also saw the omnibus bill pass, which extended everything, well, not everything, but a large subset of things beyond the 151 days that was extended prior to that to the end of 2024. Then we got the notification that the PHE was going to end. What does that all mean? And what do we do with that? Because I anticipate that the moving target will continue. Some of these policy changes that were part of the 151 day and then part of the omnibus bill also have many uncertainties that require policy level changes. So where are we? This is a great slide that my buddy Rebecca Canino did for us for a webinar. She's at Johns Hopkins, and this is the table that she has put together for herself and for her organization. And I would really recommend that you do this for yourselves as well. Create a grid. What changes, what were things like pre-pandemic for your organization? What did the public health emergency change? What happens at the 151-day transition period? What happened as a result of the omnibus bill? And some of these things are federal, some of these things are state. And so if you are going to be prepared, you really need to kind of create this grid for yourself, looking at both the state and the federal issues. I'm going to hit on a couple of things in terms of what we know right now when that public health emergency ends. One thing that we know with certainty is that at the end of the PHE, so that would be May 11th, covered healthcare providers will once again be subject to penalties for violations of the HIPAA privacy, security, and breach notification rules that occur in the provision of telehealth. What does that even mean? During the public health emergency, one of the flexibilities was that the federal government said, we are not going to enforce violations due to your providing telehealth in good faith. You've had over 2.5 years now, so technically they could have come after you before this. But we know for sure that by the time May 11th hits, that flexibility is over. What does that even mean? So we collected the top 10 evils we've seen during the PHE that violated HIPAA. And these are some of them. Having phone conversations with patients in public spaces and or using a speakerphone, big no-no. Initiating telehealth visits with patients using shared or family devices. So your kid comes home from school with the laptop, you need to grab something really quick, you use your kid's laptop for a telehealth visit. Ooh, ouch, no, can't do that. Okay, so those are things. Communicating health information with patients using unencrypted email, a big no-no. Texting with patients using consumer messaging apps. That again is not encrypted, not secure. Conducting telehealth visits on mobile devices over a VoIP or a public Wi-Fi network. We haven't had a whole lot of guidance on VoIP, but we do know that they are not secured and they can be accessed. And there's not a lot of HIPAA guidance around it yet, but it's coming out. And we've seen a couple things come out already. So we need to be really careful on that, because if you're connecting to the internet, doing your all of your interactions, whether it's a telephone message, a video call, whatever it is, there are some challenges with that. Having no mechanism for verifying patient identity and or portal account login is an issue. And we need to know that, because, you know, I could be posing to, as anybody and saying, I'm your patient and I need a telehealth visit. And if you have no way of verifying that, I could be giving, you know, my kids my password to my portal login and they can log in and see all my information. And I have no idea. So how are you going to verify that? Conducting telehealth visits using unencrypted consumer video platforms is a big no-no. Conducting visits on a telehealth platform, it could be a legitimate platform, without a business associates agreement is another no-no. Not asking or documenting who's in the room with the patient during a telehealth visit is also a no-no. And then not disclosing who is in the room with the provider during a telehealth visit. So all of those things are violations of HIPAA pertaining to telehealth. So I think most of you who are on this call, HIPAA will apply to you, but HIPAA applies to you if you are a healthcare provider that transmits personal health information in electronic form. And PHI, there's a long list of what is considered PHI. Specific to telehealth are things like IP address, email address, obviously video and images of the patient, anything that's identifiable, like their birth date. So if you have a password and they enter their password and it's their birth date and their IP address is all showing up, and you're sending them a link by email to connect to your Zoom, let's say platform, and you have a non-encrypted Zoom, the patient's at home, somebody at Zoom, if you don't have a business associates agreement with them, has access to their login, their password, which might be their birthday, their IP address, because they're connecting to you through some device where there's an IP address logged. And you just sent them the link by email. So that email is now traceable by some employee at Zoom, whether they will or not is different. And then somebody can break into that system, hack into that system and pull all that information. So you have now just violated all sorts of things with HIPAA. So what is a business associates agreement, or who is a business associate? A business associate is anyone who creates, receives, maintains, or transmits PHI on your behalf. So if you have a vendor, like I just said, like Zoom, and you're not using Zoom for healthcare, you don't have a business associates agreement with them, they are still a business associate, because now they are transmitting your patient encounter via the internet with access to that IP address, with access to the logon, with access to the email address that you sent that invite to. And so now they have access to PHI, and you have a business associate, which means you have to have a business associate's agreement with them. All right. Why am I even telling you about this? Because the penalties are actually pretty significant. These were there's like unknowing violations and knowing violations. you now know. You're listening to this webinar, so you don't have that "I didn't know any better" excuse. So sorry, I just ruined your excuse. But unknowing violations start at $100 minimum per violation, and it could go up to $50,000 maximum per violation. And that's actually adjusted for inflation each year. So that is that $100 is now like $110 or $112 from when the point that this was developed. And so the "I didn't know" was, oh, I didn't realize that I couldn't send an email to a patient that was not encrypted. The per violation thing means, if, let's say, I went out to the park and took a phone call from a patient, and I had it on speakerphone and they needed a visit, and so I texted them a link to Zoom, and then I grabbed my kid's laptop because I was sitting there after school with my kid, you now have had like 3 or 4 violations right there. So the $100 is not $100 per incident, it's per violation. So that's like $400 right there to start with, just for those 4 things that you just did. So that's why this is important to you, and it could become financially significant to you as an entity, but also to your organization who hires you and who is accountable for some of the risk management practices. So I like to start with, like, how do I prepare? I think many of you probably have like risk managers in your organizations, and you have all this information. Somebody's in charge. But some of the things that we don't realize is that, I like to ask people, like, which one of these is the real HIPAA compliance logo? And this is a trick question, because, most people will say, oh, we think it's 3, or we think it's 1, or we think it's 2. And the reality is none of these are. There is no such thing as a HIPAA compliance logo. And when you are working with software vendors, when you are working with telehealth vendors, they all claim to be HIPAA compliant. And so that is the #1 challenge that we have right now. So risk management in this space really looks at, your HIPAA controls are not just software. No software can make your program HIPAA compliant. So that's the first thing that we need to know. I think many organizations, especially smaller ones, whether it's an FQHC or a small hospital, they'll go, well, we contracted with a vendor and they said they were HIPAA compliant and they said they were encrypted. That's great. But that doesn't make you HIPAA compliant, because the software is not a covered entity. The software automation is not going to help you when you are using the software in Starbucks on a public Wi-Fi network, and people can see over your shoulder and hear over your shoulder. You are out of compliance with HIPAA, even though you're using great encrypted software. So you really need to think about that carefully. So is the vendor HIPAA compliant? I usually say, if you are an entity and you have like signed a contract, let's say a multi-year contract with a vendor, or you're about to, because like telehealth is here to stay and we need to do this, we really need you to ask a couple of key questions to your vendor. Don't just take them at face value that they are HIPAA compliant. Ask them if they have had an audit of their systems, a HIPAA audit, because part of HIPAA compliance is that all of the staff that have access to their information needs to be trained in what HIPAA is. And if they don't do training for their staff, they are not doing what they need to do. If they don't have rules for notification, like breach notification, and many of you have seen in the last few years, like these huge breaches of huge hospitals, health systems, but also vendors. If that notification policy is not in place, they are not doing what they need to do to be HIPAA compliant. And so asking for them to say, hey, have you had an audit? And having them show you their audit document is a really good first step in helping to give yourself some assurance. Because by allowing them access to your PHI, you are actually on the hook for that, because you chose that vendor. And if you didn't do your due diligence, they don't care. They're not bound by it. They're just saying, yeah, I'm going to sell you the product. And oh, yes, I have everything I need. I dotted my T's and dotted my I's, crossed my T's, I'm good. And they will give you that spiel. So ask the tough questions. Access points. You need to think about your access points and where that data flows in terms of HIPAA. So if you are in a company or an organization or a hospital, you're going to have a server, you're going to have maybe a hosting company, you have internet access, you have flash drives, keyboards, lost, stolen tech. Like, where are the access points where that information is stored? Administratively, who has permission to access that? And then technically, you have all of those technical challenges with passwords, and we all hate that, right? We don't want to have to change our passwords every so many times and have these long passwords that nobody can remember. Yet at the same time, we're bound to that if we want to maintain some level of privacy and confidentiality. And the thing with telehealth is that we need to replicate that workflow for every task. So let's say you have now providers working from home. That's very different in terms of workflow than working from the office. So let's say you're working from home and you have a dual monitors or 2 laptops, and one is accessing your EHR and one is accessing the telehealth visit from your provider. But then you're using one laptop to e-prescribe or to, schedule visits or whatever. Each of those might have different access points. So let's say I'm connected to the VPN for my company or hospital for my telehealth visit, but then I have another laptop that I'm using for my EHR, and maybe I'm connected to the VPN there. But I might be then having a tablet that I'm using for text messaging for a patient, and I'm not connected to the VPN, or I'm not encrypted there. That then creates a violation right there. And so really thinking through, like, where are all the access points and where are all the touch points with the patient and with the patient record. Now, I also mentioned that there's a difference between you working from home and you working from your office. When you're working from your office, your IP address, and if the patient's at another clinic, that's a different thing, right? If you're doing, let's say, patient is going to clinic A and I'm seeing them from my office or from home, that clinic's IP address is not PHI because that belongs to the clinic. But if the patient's at home, that patient's IP address is PHI because now we're identifying the patient or the patient's location. So we really need to think about that, and having different protocols for, how you send that link. So if they're not accessing the link securely through their EHR, through their patient portal, and you're sending that by email, again, emailing the link to another facility or workplace is different than emailing that link to a patient's private email address when they're sitting at home. So really thinking through that. So what is this roadmap that we really need to think about? We are all responsible for doing a risk assessment. So the high tech has a compliance roadmap. You can actually Google that and look it up. It lays out this really nice document that says, like, walks you through this. But the risk assessment is like, where is, what ePHI is actually stored, where is it stored, who has access to it, what are the access controls? And, usually if you have a privacy officer, they're doing this for you. But if you don't, you really need to do this. Then where's the training taking place? So who's training your staff on what the compliance issues? And then what are your policies? So if you violate HIPAA, one of the first questions someone is going to ask you when they're investigating the violation or the complaint is, who is responsible for your policy? And let me see your policy document. If you don't have any policies, you're going to be in serious trouble, because the understanding is if you're a healthcare provider, you need to have some policies around HIPAA. And so who is responsible for these processes, the processes and protocols for your telehealth visit? And that person needs to be working very carefully with your risk or privacy officer to make sure that each line item in that workflow and that protocol gets scrutinized and looked at from all different angles. So if the patient's at home, if the provider is at home, if the patient's at a facility, if the patient is at work, if the provider is at work, look through every angle that you're using for telehealth visit. Then looking at your security and then evaluating, setting up and testing and monitoring your systems. So that's the one biggest change that we know will happen when the public health emergency ends. There are some other things that are slated to also end when the public health emergency ends, and I'm going to go through those a little bit. I think one thing that people may not be as familiar with is the Ryan Haight Act and the DEA rules around that. So DEA has recently said announcement should be coming out soon, hopefully before May 11th. But until new guidance is issued at the end of the PHE, which is May 11th, we revert back to pre-pandemic restrictions around prescribing of controlled substances. What does that mean? It means that a clinician who's registered with the DEA may prescribe controlled substances to patients for whom they've had an in-person medical exam, or there's a covering practitioner that is, let's say I'm an on-call doc and I'm covering for you and you've had that in-person physical exam. Once that physical exam, in-person exam has taken place, there's no expiration date, so you can do a telehealth visit and you can prescribe through that telehealth visit. What happens is, though, many of us have had these telehealth visits where we established that patient-provider relationship by telehealth, and we've never had that in-person exam. So there's a giant question mark as to whether DEA will kind of grandfather those visits in and say, yeah, that meets the requirement because you established a relationship during a time where there was an emergency and you don't need to have a physical exam, in-person exam prior to continuing or renewing your prescription. We don't know about that yet. So that is a question mark. As of right now, what we do know is when the PHE ends, you will have had to have had an in-person exam with that patient before you can prescribe a controlled substance. There are a handful of telemedicine exceptions to this rule that happened prior to the pandemic, but they are very restrictive. So if the patient is being treated in a DEA registered facility, such as a hospital or clinic, so if the patient shows up at hospital A and you are the prescriber and you are doing a telemedicine visit from your office or your site, then as long as that patient is being treated in a DEA registered facility, you can prescribe that controlled substance. If the patient is being treated in the physical presence of another DEA registered practitioner, then you're allowed to prescribe controlled substances without having had a physical exam or in-person physical exam with that patient. Or the telemedicine consult is conducted by a DEA registered practitioner for the Indian Health Service. That is it. Those are the only restriction or the only exceptions for telemedicine. So if you are a practitioner and you never had an in-person exam with this patient and you've been prescribing by telehealth, come May 11th, you may not be able to renew that prescription anymore. So that is going to be a major challenge. Lots of organizations have written about this. So one of the exceptions that was written into the rules was that the provider is registered as a telehealth provider through the DEA. The DEA has never, and this is over 10 years old now, has never created that registration process. They have been mandated by Congress to do it. They have been, a lot of things have happened. And just prior to the pandemic, they were supposed to have issued the new kind of proposed regulations around it. They never issued that. Pandemic hit, all these restrictions got loosened up, and they were never on the hook to do it. So I'm waiting to see if this announcement that's supposed to be happening upcoming might be the registration process, or might be the grandfathering of relationships that were established during the pandemic, or both, or some complete other relaxation of the rules. We just don't know. So that is something that you all need to be very careful and be mindful of. And we also know that many providers went to all virtual during the pandemic, especially mental health providers. And this is where those controlled substances often take place. You have mental health providers, psychiatrists who are dealing with patients that would never come in to an office visit. They had their first visit by virtual, they're being prescribed controlled substances, and now what do we do with these patients? Because there's just not enough people to hand off to for in-person visits. So big challenge right now. What else might change? The rules about who the qualifying providers can be. We know that with Medicare, they've extended this whole cadre of, or at least the omnibus rule extended kind of OT, PT, some of these other providers till the end of 2024. But private providers have not. They don't go with Medicare rules. State Medicaid does not. And so those extensions may end when the public health emergency ends. So we need to be really careful about who these other providers are and whether they are actually qualified to receive reimbursement by telehealth. Another big challenge that we're facing is this audio only piece. So we know the omnibus rule extended Medicare audio only through the end of 2024. But it did not extend the rates. And so it extended coverage, but not necessarily the rate. So during the pandemic, the audio only visit had equity with the rates provided for an in-person service. That rate may change, and we don't know yet. So that's another giant cloudy question mark. And the reason it is a question mark is because there has been a lot of debate about the issue of equity. So we know that many patients are receiving audio only care because that's the only way they can get care. Whether it's broadband, whether it's digital literacy issues, whether they just don't have devices that can do a video visit. We also know that it's kind of easier to do an audio only visit. So we have heard anecdotally and in some data that oftentimes providers and patients will just opt to do an audio only visit because they can, and it's a lot easier, and it's just, it's just easier to pick up the phone than to get someone to enable their video and do that video visit. So the challenge is here, this issue of equity. There's going to be a subset of patients if the audio only goes away, or if the rate gets much lower, providers are going to say, I'm not going to see you by audio only, come into the office. And that those patients aren't going to get seen. But this is, a calculation by many hospitals and health systems. They're going to have to say, do we allow our providers to spend half an hour on a phone call for, $10, $15? We don't know what that rate's going to be, when we can get that patient to come in and get the full reimbursement rate. So studies have shown that there are definitely rural disparities related to broadband. And so if you don't have broadband, you can't do that video visit, or at least not a quality video visit. So is this going to leave kind of many rural patients behind? We're also finding that in research that it's not just rural. This is happening all over the country, whether it's urban or rural. That there are a subset of patients that just have difficulty with video visits. So I think there are many researchers now really rethinking and doing some studies on the impact of audio only visits on health equity. So ongoing delivery of audio only visits can reduce the quality of care among low income populations and contribute to health disparities. Generous parity reimbursement for audio visits could be creating a perverse incentive to deliver substandard care to the most underserved. Yet at the same time, are we comparing this to no care at all? And so this is where the policymakers are debating. The people behind Medicare and Medicaid are also debating, what do we do with this audio only rate? So this is another wait and see. We just don't know what's going to happen with the rate setting for that. I wanted to leave time for questions. So just quickly, where you can find some resources. So the Mid-Atlantic Telehealth Resource Center is one of many resource centers federally funded by HRSA. And so we are the ones that cover the dark purple states, but you can find telehealth resource center serving every state in the country, as well as the US affiliated islands. You can reach us at telehealthresourcecenter.org, and that's the national consortium where we are kind of all housed, and you can figure out where your resource center is. We just started a collection called the End of the Public Health Emergency Collection. And so if you go to the telehealthresourcecenters.org website, at the top menu bar, you'll see something called collections. And if you click on that, one of the collections, if you scroll down to the bottom, is called End of the PHE. And if you click on that, you'll see that there was a webinar that we actually hosted, Mid-Atlantic hosted, that was done 2 weeks ago, that has a lot of this information, but that slide that I showed with Rebecca Canino, with what John Hopkins did, she did a webinar for us and really just said, we are a hospital health system. This is what we are doing for provider communications. This is what we are doing in setting up spreadsheets. She has a sample of this great, amazing Excel spreadsheet with every single CPT code, and whether it ends at 151 days, whether it ends at the end of the omnibus bill, whether it's a code, a category 3 that CMS is waiting to see, whether it has been made permanent. But those are the kinds of things that I encourage all of you to start working on, because you're going to need to know and assess some of your risks. If we continue to do this audio only, what is our risk financially? If we continue to do this by video, at what point do I need to stop? And how do I prepare my providers to do that? If I continue to do these things, even though they're allowable, will I even get reimbursed? And at what point will that change? And really looking at that carefully. So that webinar, I would highly recommend that you read over or view, because it's there and it shows what one hospital health system is doing to prepare for that. One thing that she also talks about is provider communication. So in that collection, there's a provider communications graphic. For all of us, we are in probably hospitals, health systems, or organizations where people are on social media. They're hearing things all over the place. And this information is out there and pretty rampant. And so you're going to have providers panicking because they heard from someone, or someone posted something that they're not going to get reimbursed for this, after tomorrow or after the next day. Or we even had that in our large hospital system at University of Virginia, where I am, where somebody saw that, some provider was not going to do audio only, and suddenly it was blasted throughout the health system, they're not reimbursing for audio only, you need to stop doing that. And that was not the case, but it just got crazy. And so managing those communications as we approach some of these deadlines and due dates, and where information is going to be going out there, is going to be really important for your hospital and health system. This is my contact information, and I am going to stop sharing and just open it up for questions, because I think this is an area where we are all struggling at the moment.
That was excellent. Thank you. We did have a question during your presentation that was inserted into the chat. It states, I thought that the new rule said that what happens at the patient end is not in control of the physician, and the physician cannot be held accountable.
So yes, you're not accountable for what happens at the patient end, but you are accountable for helping the patient to understand that. So, for example, if I'm a provider and I'm text messaging you using an unsecured, unencrypted text messaging platform, because my patient wants that, that patient needs to understand what the risks are and actually consent to those risks. If that patient is using unsecure email and they want you to email them to it, you should not be doing that. And I'm just going to say that because that is something that's initiated by you, and you're sending that to them. There is a gray area on whether, if the patient consents, it's okay. The jury is still out on that. I think many people are taking that kind of like, let's cover CYA and just get the patient to sign a consent and saying, yeah, I understand the risks and I'm willing to accept that. So far, we've had no lawsuits around that. But if you have other alternatives or other options, I would definitely explore those until we get some really strong guidance around that.
Excellent, thank you. Okay, so she replied, thanks for clarifying. I agree, sending PHI unsecured is foolish. Okay. Thank you for your question, Sheila.
Yeah. And I'll also say, like, one of the things that, with HIPAA is asking who's in the room. So, obviously you're going to have to trust what the patient says. But documenting that means that you did your due diligence. So, with HIPAA, you really need to know who else is in the room. And, I'm using a Zoom background. You have no idea if I have like 30 people sitting behind me. And your patient can do the same thing. But for you not to ask, the onus is on you. Suddenly, if that's not in your policies and procedures, so this is where I think documentation is really important. So I think every organization needs to have a set of policies and procedures. So for every visit, you're going to ask that patient and you're going to document in the record, we followed our policies and procedures around this. So is somebody else in the room with you that can overhear our conversation? Yes or no? The telehealth visit doesn't need to end if there is someone in the room, but you need to document who's in that room, and you need to say to that patient, do I have your permission to have this other person overhearing this conversation in the room, and you document that in the record. Then you are following your policies and procedures and with that patient's consent. Now, there are also situations where if someone's in the room and let's say this is a patient that is a domestic violence or, abuse victim, you may want to also have some policies and procedures around that, because just because that patient says, yeah, I have someone in the room, it's my husband. If you suspect that husband is, an abuser and that patient is going to be at risk, you should probably discontinue that conversation and then pick up the phone at a time when the patient is secure, and create what is best practice is a passcode or a password. When I'm with you, let's create a phrase or a passcode where you can tell me when you feel safe to talk. And it could be as simple as like, did you go to Walmart today? And they answer yes or no. And so we'll start every conversation with, did you go to Walmart today? How was your trip? And they say yes if they feel safe, and no if they don't. But you can create some of those policies and procedures and document those in the patient record as well.
Excellent, thanks. And we had a couple of questions about the slides in the recording. So yes, we will share a copy of the slides as well as a link to the recording. If you give us about 24 to 48 hours, we should have that posted to our website, and we'll send an email out to everyone that registered so that you have access to those things. But we still have plenty of time. If anyone has any other questions that you want to drop into the chat or unmute, please feel free to do so. We will be happy to answer those questions. And I don't see anything else right now, but we'll hang out and give it a couple of minutes.
Yeah, and I went through those materials really quickly. So if you want to ever go back or
it was great. It was a lot of great information.
I guess mine is more of just a general question. Is there a preferred list or a list of vendors for the technological, the technology side that the center has worked with that you feel